the recording, please, Jordan. Great. Welcome to today's overview and introduction to the Pakistani Community Health Profiles. I'm Dr. Justin Varney. I'm the Director of Public Health for Birmingham City Council, and I'll be talking through the profile a little bit later this morning. Just to start with some housekeeping for everyone, if we can ask everyone to stay muted during the webinar and ask you to turn off your cameras, then that will help protect the bandwidth for others that are watching it as well. If you have questions during the presentation, please pop them in the chat or use the raise hand function. We are recording the webinar, just remind everyone of that. And we will be using Menti during the webinar as well to get feedback from you. The webinar will be available afterwards, and that will include both the audio and visual, and we'll be putting that up on our YouTube channel. This is one of a series of presentations of the community health profiles, and as I said, today we're focusing on our Pakistani community health profile. So I'm going to hand over now to Councillor Mariam Khan to say a few words of introduction and welcome for today's presentation. So over to you, Councillor Khan.
Thank you, Justin. Good morning, everybody. As Justin has said, my name is Councillor Mariam Khan. I'm the Cabinet Member for Health and Social Care at Birmingham City Council. So I'm so delighted to see the launch of so many of our community health profiles, and so pleased to be welcoming you all to the launch of the Pakistani community health profile. Just last Friday, we launched the Muslim community health profile, and as a Brummy with Pakistani Kashmiri heritage, I'm proud of how diverse Birmingham is and of how welcoming that we are to people who choose to make this city their home. However, we know that not all of us experience the same levels of good health and well-being as each other, and that there are real differences between communities. In the council, we take this seriously, and we see that tackling these unfair differences in health as a core component of the work that we do. The community health profiles have identified and summarised the physical health, the mental health, lifestyle, behavioural and wider determinants of health-related issues affecting communities, both locally and nationally. The findings from these key public health documents will shape how we address, protect and prevent health inequalities in our city. And we've always struggled with understanding some of the detail of these inequalities, and this is where our health profiles will come in. The Public Health Communities team have, in partnership, developed a series of evidence summaries that focus on helping improve our collective understanding of our diverse communities, the health and well-being challenges and key inequalities that they face. I hope that you find this session useful, and I'm sure that you'll find statistics in this presentation which you can take back and share amongst your organisations and groups that you're involved in. We've got the opportunity here today to share our approach and findings with you, and afterwards we'll look towards how we can work together, not only for our respective communities, but for Birmingham as a whole. Attending quite a few of these health profile launches and actually having conversations with people outside of these meetings, it's clear that there's a need for having this information and data broken down in this way. And one of the key things that we find is it's not just something that the City Council will be using across different directorates of the council, but also this is like more or less like a toolkit where these health profiles have been launched and are available for organisations across Birmingham to be able to use and shape some of the work that they do in tackling health inequalities. And without further ado, I'll bring back Justin in so that we can get started. And I know that we've got a lot to get through, as well as having the Mentimeter discussions where everybody else here will get a chance to get involved and give some feedback too. So thank you for attending, and I'll hand over back to you, Justin.
Great, thank you, Councillor Khan. And just to remind colleagues who've joined us, please keep your cameras off and mute yourself, and it will help us keep the bandwidth protected for those with more difficult broadband. So we're going to start with the Mentimeter, and this is just an opportunity to get familiar with the approach. So if you go to www.menti.com, you can use your camera, come against the picture on the screen to use the QR code if you're using a camera to take a picture. And when you get to the link, the code is 2708 2507, and that should land you on a page which has a picture. Not sure it will show you roughly like that on your phone, or if you're accessing it by the laptop. And we'll be using that through the presentation to capture some more information about you, but also get some feedback about the profiles. So first of all, I'm just going to talk a little bit about the profiles and where they come from. So Jordan, if we can move on to the next slide. So there are two types of report that public health have to produce, and that's part of the statutory responsibilities of the council in relation to public health. So the first is the joint strategic needs assessment. That's a snapshot of the health and well-being of the city, and we update that every couple of years based on the information that comes out predominantly from the census, population surveys, things like that. And that's why it's not necessarily updated every year. And the next iteration of the joint strategic needs assessment will be coming out towards the end of the autumn, because we're incorporating the latest data from the census into it. The second thing we have to produce as part of public health responsibilities is the annual Director of Public Health report. That's a report that I produce with my team, and it's my independent report to shine a light on a particularly important issue. To be fair, the council doesn't have to publish it, but in Birmingham we've never had a problem where the council has decided not to publish the public health report. And this year's public health report is looking at the role of digital in health and well-being, looking both at the pros and cons that the digital world contributes to our lives. So they're the things we have to do. Then there are a series of things that we choose to do because we think it helps the city and our partners and the council and others act to address inequalities in our communities. And there are three different types of evidence-based reports. The first is a deep dive. That's a bit like a mini joint strategic needs assessment, takes about 18 months. Both involves looking at data from services, published evidence, but also engaging with communities, doing focus groups. So it's quite a large piece of work, and it makes very clear recommendations for action as well, based on the evidence of what works as interventions. The second quite long running piece is topic-based commissions. And these are where we work looking at the evidence, but we work with communities to collaborate on co-producing evidence-based solutions. And we have two topic-based commissions. One is the Black Ear Programme, the Birmingham and Lewisham Africa and Caribbean Health Inequalities Review, and the second is the Birmingham Poverty Truth Commission. And those run over several years. So the Black Ear piece of work is now coming into its third year, and the Poverty Truth Commission is the second iteration. The commission is coming to halfway through its first year now. The third way that we produce reports where we're choosing to take action is in community health profiles, and these are desktop pieces, so we don't run focus groups. These aren't things where we go out and engage people. They are purely looking at what the published evidence says around inequalities, around specific communities, and they provide a snapshot for us on which to then build community conversations and increase understanding of these communities as well. So moving on, the community health profiles are framed alongside our strategy becoming a bolder and healthy city, which is the strategy of our local health and wellbeing board, and they help us understand the gaps in inequalities around a specific community of identity, of interest or experience. So they're separate from profiles that we might do, say, on ward level, where we're looking at a specific geography of the city. These are focusing on a community of identity, interest or experience. They set out the evidence of the need, and the aim is that they help us both as a council but also our public sector partners to better understand what's going on. We aim to refresh them every 5 to 8 years, and the reason we don't do it more frequently is the majority of the evidence we draw on comes or is linked directly to the census, which is done every 10 years. And the data on many of these communities is only released every 2 or 3 years. So the census data doesn't all come out at once. It comes out in a phased way over the 10 years between the census. And what we're aiming to do when we get the update on the population data from the census, which is one of the early releases we're expecting later this year, is we produce an annex to the community health profile. So instead of rewriting the whole profile, there'll be an extra annex which will sit alongside it, where there is updated data in the short term, and then every 5 to 8 years we'll go back and look at all of the research evidence, because hopefully there will be more papers published, more reports published, more evidence about what to do and how to make a difference. And that's why we take our time in terms of updating them. So looking at the plan about what we've done, as I mentioned, the two commissions, the Poverty Truth Commission, the African Caribbean Health Inequalities Review on the right-hand side of the screen. In the middle is the list of the deep dive reports, and we're working towards the learning disabilities, dual diagnosis and mobility impairment reports coming out later this financial year, so before the spring. And then the community health profiles, which is what we're talking about today. And as you can see from the arrow, today's one is focused on the Pakistani community, but there are a range of other community profiles. And in most of them, we've been doing specific webinars around the individual community profile with those communities, so that you can understand more in depth some of the differences. And it has been quite important. I think a really powerful piece of learning around the community health profiles is that too often we homogenize communities. We just lump everyone together. And Birmingham has made a very strong commitment to go beyond this language of BAME and saying everyone who's not white British is the same. We've got to dig deeper. And the Pakistani profile alongside the Indian and Bangladeshi profiles are examples about where we're going even further. We're going beyond that label of South Asian to say actually there are differences in the evidence, and just assuming that the Pakistani population has the same health inequalities, the same health challenges as the Indian population does a disservice to both groups. So that's where we're going further in these community profiles to really start to understand this. And we're one of the first areas, both in the UK but in the world, to actually dig deeper in this way, to try and better understand our communities in more detail. So the community health profiles aim to help us understand inequalities in health. That's the gaps in health, both in physical health, mental health, the behaviours that underpin our health, but also the environment in which we live, those wider factors, those wider determinants that drive our health. We frame them around the 10 key priorities of the Bolder Healthier City strategy, and that's so they directly link across, but they're also linking across to a strategy where we're trying to change things. And that's a very intentional decision to try and drive change and make sure that inequalities are considered specifically in the work of those strategies. The second phase of the community health profiles is that we commission community engagement partners to work with us over a year with the local community to look at the profiles, to sit down and say, where do you want to prioritise action? There's a bit of pump prime money to start community co-produced solutions, but also to capture case studies to better understand where there's good practice going on. And that will then provide a second document that will sit next to the community health profile, which is kind of so what. So we move on to the next slide that just sets out the 10 themes of the strategy, and I won't dwell on those in detail, but they're there and you'll see them threaded through the profile as well. So if we move on to the next slide, I'm going to invite a colleague I think is with us from Hawkmoth Consulting, because this is one of the profiles where we commission an external partner to provide it, to talk to us a bit about the methodology that was used. So over to you, colleague.
Hello, thank you. My name is Maria. I'm the head of the Centre for Government at Hawkmoth Consulting. We're basically specialists in community research, so community focused research and engagement. And we were commissioned by Birmingham City Council to produce the Pakistan health profile, with really the focus being on physical health, mental health, lifestyle, behavioural and wider determinants of health-related issues, with a specific focus on information which is local, so from the West Midlands and Birmingham, and then from across the UK. We used a combination of both quantitative and qualitative information. So all the information we've used is from open source data. So you should always be able to go off and go into the endnotes and find the exact information that we've been using in the reports. On the quantitative side, we've used data from NOMIS, ONS, gov.uk, PHE fingertips, and there's a lot of useful information out there. And essentially what we've done is we've taken that data and we've crunched through it, we've interrogated it to make sense in terms of all the different themes in the report, to really understand, where are the gaps, where are the strengths in the community. So of course, it's not just about highlighting where there are struggles within the community with a certain health condition, but also where are the strengths, where is a community actually doing quite well as well. And then on the qualitative side, we've used a lot of academic research. There's a a lot of useful reports from the voluntary third sector organisations as well. We've used a website called PubMed. They have a lot of very useful academic science-focused academic research. So for each theme, we've very systematically gone through it to just identify where is there a research conducted, perhaps a focus group or one-to-one interviews, which focuses on each of those themes. So we've drawn that out. And what's actually quite useful is you can marry up the quantitative, the data side of things with qualitative analysis, which really adds the flesh onto some of that, the kind of insight we're providing, because really it's not just about the data. The data is incredibly useful, but it's actually trying to understand the lived experience. What is the day-to-day life of a Pakistani person, and therefore where do these conditions actually really impact them? That's where the qualitative data actually becomes very, very useful. We had an exclusion and inclusion criteria, so we didn't use anything from before the year 2000 unless it was providing a comparison to more recent data. So if we could actually see there is a change, then it's actually quite useful having something from before that, but we didn't use that as the focal information. And I would say because the bulk of the information that we were trying to really ground all of this, the themes in, was the census data. Most of that is from the 2011 census. And just to sort of flag, there is a new census coming out as well. So it'd be really interesting to see how things have changed from, say, 2001, 2011, and now the next one. And as the data's coming in, I think we're already getting a bit of a snapshot how things have evolved. And very quickly, sorry, just in terms of some of the other kind of exclusion criteria, where we didn't take information from abroad. So we didn't look at information, say, from Pakistan or any of the diaspora, which is based in any other countries. We only focused on the UK and more specifically Birmingham and West Midlands. I think just very quickly, there were some knowledge gaps. We could very quickly see that there is less research in some themes and more research in others. It would be quite useful, therefore, to just highlight some of those gaps as well, so that some more research can come out off the back of that. But overall, I think from our perspective, these reports are really useful because it actually there is a real world application for it. I, as one of the writers of these reports, I was going through preeclampsia as I was writing the report. And so the maternal care section was very real for me as I was going through all of that. These issues are very real. They do impact people on a day-to-day basis. And so these profiles go through the entire journey of one's life. So I hope this acts as a very nice starting point, and we can build upon them as the years go on.
Great, thank you. And it's been really good working with Hawkmoth on this and several of the other profiles as well. So the profiles will be published on the council website, both the profiles themselves, the written report, but also a slide set to go with them. We're aiming to translate the profiles into at least one other primary language where it's relevant. We can't do it for all of the languages, and I'm conscious in the Pakistani community there are multiple languages spoken, but we are trying to do it for at least one. If we're able to afford to do more, then we will. And we're running webinars as we are today to help share understanding and awareness of the profiles. So let's get into the detail of the Pakistani profile and talk a little bit about what it has. And this is just some of the content. These documents, I have to say, I'm really impressed at the thoroughness of what's included in them. And the documents range from about 80 to 120 pages themselves. So we've just pulled out a bit of a flavour of the profile today for you. So first of all, there's an overview of the Pakistani community. In the report, it includes a little bit about the history of Pakistani community in the UK and specifically in the West Midlands and Birmingham. It talks about some of the cultural contexts, such as the faith context, and also sets out some of the geographical differences in terms of population density, which we can see predominantly from the census data. The overview of inequalities that the profile provides highlights these as kind of headlines. So these are the ones where there was strongest evidence or most visible gaps between the health of the Pakistani population and comparators. So high rates of child poverty, high rates of childhood obesity, lower rates of physical activity, particularly in Pakistani women, greater prevalence of cardiovascular disease and diabetes, barriers accessing health services, more overcrowded households, and lower consumption of fruit and vegetables. And it's important to say that although these sound very negative in a sense, one of the reasons we write the profiles is to identify the gaps. So by nature, they are quite deficit focused. They are focused on the negatives. Then there are lots of positive and great things about our Pakistani community in Birmingham, but because they are focused on inequalities, they are by nature looking at the negatives in terms of the context. So moving on to some of the themes that we'll be highlighting, and I can see someone's asked around, is the Pakistani community the largest ethnic community now in Birmingham? I think we'll have to wait for the next census to see. It certainly was one of the largest at the last census. We'll go through the slides and then we'll take questions at the end, because you may well find some of your questions answered, or pop them in the chat so you don't forget them as we go along. So in terms of getting the start in life, which is focused at maternal health and children's health, there's a high risk of congenital abnormalities. So those are abnormalities that children are born with, high rate of stillbirth, and also a high rate of lower birth weight, which is associated with worse outcomes for small babies, high prevalence of obesity, and lower household income when looking at child poverty. So some real challenges were highlighted from the evidence. And what you'll see through some of the themes is that it varies in terms of how much is there. And that's a reflection of how much research has been done, specifically how much research has been done. Well, we can see that the Pakistani community has been considered specifically and separately to other South Asian communities or to other non-white British communities. So moving on to the next theme of mental wellness and balance, we see some differences in terms of the rate of adults using mental health services being lower than the Bangladeshi community, but higher than the Indian. I thought one of the things that was really interesting in this profile was where the hawk moth were able to, they compared and did comparisons both between the Pakistani community and the general population, but also with other South Asian communities like this. And I think that opens up some of the conversation about differences between our South Asian community. There's also been some specific research around barriers to access and some of the challenges there are. And Hannah's put in the chat box some of the services that are available. And it's important to recognise that through the work we've been doing on these profiles, where we've been able to get some of the early findings, we have taken action. And although there's not a direct correlation for all Pakistani communities, we have, through the work we did on the Muslim profile, identified issues around barriers for mental health for Muslim communities and commissioned Delicate Mind as a specific provider to provide additional mental health and wellbeing support for a Pakistani community. So there are some examples where we found things and we've already started to act, and I'll highlight others as we go through here. So moving on to healthy and affordable food, we do have data by ethnic community in terms of obesity, which shows a lower rate of obesity in Pakistani women than Black Caribbean women, but higher than Indian and Bangladeshi women. So some differences in our South Asian community, but also compared to other non-white British ethnic communities. And there's been some specific work looking at waist and hip ratio, which has links both to diabetes and to cardiovascular disease. So there's some interesting differences that, as you can see, the report pulls out around the Pakistani community compared to the Indian and Bangladeshi community. And I think that shows the value of these profiles as they help us understand some of the differences rather than just assuming everyone in the South Asian community has the same risk and the same challenges. Moving on to physical activity, actually another area where we're able to get some more detailed information based on ethnicity. Really powerful finding that Pakistani women are amongst the least active of all ethnic communities, and Pakistani men are one of the least active when we look at the number of adults achieving the recommended 150 minutes of physical activity a week. Now that's really important because you remember from some of the earlier slides the evidence of increased risk of diabetes and cardiovascular disease, of heart disease. We know that if you are achieving that 150 minutes of moderate physical activity a week, that's physical activity where you get a little bit warm and a little bit breathy, but you can still have a conversation. So a brisk walk would be moderate activity. You can reduce your risk of type 2 diabetes by about 40%. So big impact in terms of being able to reduce the risk of diabetes and of cardiovascular disease, to reduce hypertension, high blood pressure. Physical activity can make a real difference. And I think really sad that this this kind of correlates with that finding. So we know that these diseases, which are more common in Pakistani community, actually also one of the behaviours that can really improve them and reduce the risk of those diseases developing, but if you have them, can also make them better, can reduce the need for medication, which is being physically active every day. That is lower in our Pakistani communities. What's interesting is rates of physical activity in Pakistani children are higher. So there's something happening as Pakistani children become Pakistani adults, that it slows down, and that's something we're going to need to, I think, explore as we move forward. Moving forward, some of the themes look at those wider determinants, those factors around us: housing, education and employment, and some of the gaps there and some of the challenges there. So as you can see, proportion of the population live in social housing, higher rates of overcrowding in Pakistani households, but also in our Bangladeshi population. And in terms of employment, looking at the employment rate, and in the report you have more comparators to be able to look at whether it's higher or lower than other local communities. Moving on to what's called protect and detect, which is around screening, but also around infectious disease and health protection. There were some interesting findings there around breast cancer screening particularly, and that does appear in some of the other profiles as well. The breast cancer screening, Pakistani women are less likely to attend when invited, and that's really worrying, because we know that the earlier you can detect breast cancer, the better the outcome. And the mammography, which is not particularly comfortable, it has to be said, for women, but where we take a type of X-ray of the breast, can identify breast cancer before you can feel it. And that's really important, because by the time you can feel a lump in your breast, that cancer's already been growing for a while. Whereas if we can identify it when it's much smaller, and that's what the mammography is trying to do, we've got a much better chance of giving you a good outcome. So it's really important we understand some of the differences when it comes to cancer screening, and when people are being diagnosed late. And you can see that coming through in some of this evidence. So moving on to aging and dying well, which will be particularly relevant to the point that Samira has said. Actually, there's some work going on around end of life. And Samira, if you, one of my team will get in contact with you, because we have a team that work on aging and end of life, and it'd be great to connect that with the Compassionate Cities programme work that we've been doing. But this section also highlights some of the chronic disease or long-term conditions like diabetes. And this finding that Pakistani men are almost 3 times as likely as the general population to have type 2 diabetes, and Pakistani women are over 5 times more likely than women in the general population. A really powerful finding, and something you kind of go, how much is that understood by a local Pakistani community, and how much is understood by our health and social care professionals working with them? The leading cause of death in the Pakistani community for both men and women being heart disease, and there are lots of things that we can do to reduce the risk of developing heart disease and of dying from heart disease through getting people more active, reducing smoking, improving diet, but also ensuring that people attend things like the NHS Health Check programme, where we do look for early signs of these diseases, and we're able to intervene and make a difference. So there are some real opportunities, I think, as you can see. these are all things that can be changed. They're not inevitable. And that's one of the really important messages, I think, to take home from the Pakistani profile, is that there are quite a lot of areas where we could make a big difference if we work better across the system with the community. We also included in the profiles looking where we were able to look at what's called closing the gap. So things, inequalities within a community. So where we were able to find information, for example, about disabled people in the Pakistani community or LGBT people in the Pakistani community, that's where it's included in the closing the gaps. In many communities, we struggle to get any evidence that goes beyond differences between men and women. And it's one of the reflections, I think, across the community profiles at how limited our understanding is beyond that kind of first level of diversity. And we need to do better. We need to do more to understand some of the inequalities within the community, as well as between the Pakistani community and other ethnic communities in Birmingham. We also included, as these were being developed through the coming out of the COVID pandemic, about how the COVID pandemic had impacted on the community as well. So moving on. Now, as I said, the reports are quite thick documents. There's a lot of information in them. So we've also created some short infographics, which are kind of the easy read versions of them, and give you more of the kind of headline data coming through. So I'm not going to read these in detail, but they're there just to illustrate kind of how we've tried to pull out the highlights and some of the key findings. And as Maria highlighted, the report is fully referenced. So when you have a look at it, you want to go, well, where did this data come from? What's the research? You can go into the report and pull out the specific finding. And as I said, where we're able to compare two populations, it's in there. So you'll see in the infographic, sometimes it compares to other South Asian communities, sometimes it doesn't. It compares to white British, but there is more information in the bulk of the report. It's just we've tried to pull out things that illustrate the gaps into the infographics, which I think is really important. The next steps in terms of what we're doing with the community profiles is we're going into, we're commissioning community partners to work with us to work over a year with local communities to sit down with local communities and go, so what? What does this mean for us? Does it resonate? Does it reflect our lived experience? And what's going on to try and fix it? There is, as part of those contracts, a small amount of money to pump prime initiatives to help co-create community-led solutions. And because we have lots of profiles, we can't keep doing that forever. So each profile has a year's worth of funding attached to it to work with a community profile partner. And those opportunities, if you're a community organisation that's interested in that, then please go to the Find It in Birmingham portal, which is where the council puts all its contracts out, and that's where we're tendering for those partners moving through. So we're now going to go on to the Menti piece of work. Before I do, I know that Dr. Iqbal has had his hand up patiently. So Dr. Iqbal, just before we go to the Menti, while people are getting their Menti set up for the questions, I'll pause to let you ask your question.
Sorry, you want me to ask a question now?
Yes, please, Dr. Iqbal.
Okay. Pramod Iqbal, I have been a long-standing member of the community in Birmingham. 2013, I wrote a book called Dear Birmingham, which was to draw attention to the Pakistani exclusion in the city. And I advocated that we needed take a targeted approach on the community. And there was a section on health, which was, cobbled together, nowhere near as comprehensive as your document here. And the point I want to make is you talked about going deeper, and I'm really impressed with what we're doing, and I'm really impressed with the report as it is. But I would say that we need to continue to go deeper, because if you go into the Pakistani community and look at the diversity, 75%, not 60% in Birmingham, but 70 to 75% of the community are from Kashmir. We need to move towards an understanding of the Kashmiri community. One of the problems with the Kashmiri community is that sometimes Kashmiri community is not employed in the sectors. And also people say, oh, we speak Urdu, when they actually speak Pahari Mirpuri. And we need to continue to go digging deeper in order to get to the point where we understand everything. And actually, Kashmiris are not the only ones in the Pakistani community. There are the Pashtuns, Punjabis, a whole range of communities. When the community is of 200,000 plus, we need to continue to dig deeper. And I'm glad that we've started to do this kind of thing. I'm currently a member of the Blatcher group, and so I'm an educationalist, diversity practitioner, but I've been pulled into the health area, and I'm currently on Blatcher. So I'm here as a resource. I'm here as a learner. I'm here as doing whatever I can to help in this admirable task that for once is now doing what we should have done many years ago.
Great, thank you very much, Dr. Iqbal. And I think your point about the Kashmiri population is a really important one. It's one we have wrestled with. One of the and I think we will, over the year of embedding, have an opportunity to start to unpack a little bit. The big challenge, and as I said at the beginning, the community health profiles are based on published data and published evidence. And at the moment, key tools like the census do not offer an opportunity for citizens from our Kashmiri community to tick a box that says Kashmiri. Their only option is Indian or Pakistani. And I think it is an increasing understanding of that nuance. And we have a similar one with our Nigerian community profile, where Nigeria has many tribal communities who have quite different beliefs, practices and inequalities, and we found a similar challenge in that. So it is a journey. This is not the end of the journey, but it is, as we dig deeper, it gets more complex and we get more understanding, which is exactly why we're doing it. I'm going to pause and just ask Mr. Hussain to come in next, and then for colleagues who are on the Menti, while the opportunity for Mr. Hussain to talk, if I can ask my team to launch the Menti and move us on to the first question, then we can start people doing the Menti while we listen. So do you want to come in with your point, Mr. Hussain? Are you there, Mr. Hussain? I can't hear you at the moment. I think we're having problems hearing you. Oh, there you are.
Yeah, right. I've got 2 or 3 points to raise. One is the inequality in health for the ladies and gents and kids. Where is the issue? Is it the lifestyle of this population, or is it the health sector itself not doing their job? Second bit is, in these 3 wards that high population of Kashmiri Pakistani community, have you looked into the quality of the food, such as takeaways? Because there's so much, the numbers is unbelievable, and that has its contribution. And thirdly, the raising awareness. Is the local authority is doing their bit, checking the quality of these outlets? Are they providing healthy food, or are they providing the poisonous food?
Sure, thank you. So what I'd encourage you to do is first of all, if I ask you to mute, because we've got a bit of a feedback loop going on, thank you. So if you have a look at the report, you'll understand a bit more detail about why there are inequalities in particularly in life expectancy and some of these health outcomes. And you raise the important point around saturation of fast food takeaways and the work that we're doing in the council through our food strategy to improve the food offer in Birmingham. And that's not just specific to the Pakistani community or particular, although it's more concentrated in some parts of the city. Across the city, we have a real challenge that is easier to eat unhealthily. It is more affordable to access unhealthy food than it is to get affordable food. So I think there is a whole piece of work on that, and if you're interested particularly in the food stuff that's going on in the city, please have a look on the council website under the food. If you put food in, it will almost certainly take you to our work on creating a healthy food city, where there is a huge amount of work going on, and some of that is specific around different ethnic communities. So we've commissioned work with the Diverse Nutrition Association to look at the Healthy Eating Guide, which is produced nationally and is based on a very white British diet. And we've worked with them to work with the communities to redesign that in the context of cultures of heritage, so that it's re-profiled and redesigned in terms of different communities' heritage food. And Hannah has very helpfully put the link in the chat, which will take you to more of it. But I'm going to move us now onto the Menti, because there'll be an opportunity for everyone to feed in. The first Menti question just gets a sense of where is your mood at the moment. It's just a bit of a practice one. If we move on through the next Menti, please. And these ones are just to get a sense of who's in the room. So we'll move through them relatively quickly to get to the important bit at the end around kind of what your view is of this. So if you start with what's your age, so just press on the button for what's your age. And as you can see, the little number, the little man in the bottom corner tells me how many people are taking part. So we're getting up to 7 now. There are about 30 of us on the call, so hopefully colleagues will be clicking submit and getting that in reasonably quickly. And brilliant.
Sorry, Justin, it's Mr. Ali here. Would you like this just the Pakistani diaspora answering this, or everyone?
No,
on the
everyone who's on the call, because we will ask about your ethnicity in a second, which is one of the reasons we do this, because it tells us who takes part. These webinars are to share understanding, awareness of the profiles. So we expect there to be quite a diverse group of people in the room, and that's why we ask, because otherwise we get to the end, and if everyone in the room is not from the Pakistani community and there's a very strong view about what we should do with the profiles, then we kind of view it differently from if it's a much more mixed audience. So everyone can take part. If the team can move on to the next one, this is where we'd like you to define your ethnicity for us, and we use this rather than the checklist approach. Exactly from the point we were talking about this morning, a bit about if we use the checklist and we use, say, the census checklist, people who particularly identify from Kashmir region may not be able to self-identify that way. So we use the word cloud or the word free text to allow you to self-define your ethnicity for us. So if you just pop those in. Brilliant. So range of people in the room. And if the team move it forward on to the next one, and similarly, what's the religion that you identify with? And we use the same set of questions across all profiles. So you might look at this and go, why do we want to know your religion when we're doing the Pakistani profile? And that's so when we look across all of the profiles, and we've done profiles for our Muslim community, for example, for our Sikh community, and for our Hindu community, we can look at who comes to the webinars and see if there's no representation. As you can see today, we're not joined by any colleagues from our Jewish community. If we move on to the next one. And similarly, we're asking, do you consider yourself to have a disability? Again, this year we've published profiles for our hearing impaired and deaf community and for our sight impaired and blind community. So again, we've been doing webinars working with our community embedding partner BID to raise awareness of these profiles. And if we move on to the next one, everyone's getting faster at it now. I can see with a little person in the bottom. And then the final bit of the demographic one is just the first part of your postcode. And again, this comes to the point of, are we talking to people in Birmingham or are we talking to people across the wider West Midlands? So we don't show on the screen everyone's postcode because it's part of protecting the anonymity, but we just want the first bit. So B1, B36, whatever it is, just that first bit will help tell us roughly where people are from. So if we move on, team. Right, so that's been the bit of the demographic. If you're still catching up, don't worry, you can keep going and it will bring you eventually to where we are. So the first question is, how can you help us share this with the Pakistani community and with key stakeholders? And Mr. Hussain raised the question of, it's one of the challenges that local health providers or social care providers don't understand the Pakistani community well enough and aren't necessarily providing services in a way which work for them. And that's one of the reasons that we have this profile, and I'm delighted that Salma Yaqub, I can see, has joined us today. I think it's probably just her little bubble that appeared, who's the lead in the NHS integrated care system on inequalities, and we're working with Salma to help ensure more of our health providers are aware. I know there are also colleagues from the Community Health Trust who are on as well. So if there are any thoughts you have about how you might be able to take this, some ideas there about taking it to your team meetings, it's always a brilliant way. I know Mr. Ali mentioned it came on, I know he'll be talking about it in his local radio show as well, I'm sure. So we don't write these documents to sit on the shelf, and so it's really important for us that anything you can do to help us get these out, please pop that in the Mentee and it will help. If you've got a specific connection you want to make with us, then please message either Jordan Francis or Hannah Thomas in my team, who'd be more than happy to have a kind of one-to-one conversation about if there's anything specific you want to do. If we move on to the next question. And this is a little bit of a pivot one, so it may not be relevant for everyone, but if you work in say social care or you work in education, have a think about how you might take some of the findings from the community profile and how it might impact on the way you kind of do your day-to-day business. So as I said, it may not be relevant for everyone, but particularly if you work in our health and social care settings, or you work in education, or interestingly, as someone raised in one of the previous profiles, we should be taking these community profiles to the Chamber of Commerce and sharing them with employers to help employers think about actually how are they providing a positive work environment for our Pakistani community, and what can they learn around some of the inequalities that affect our Pakistani community. So we'll move on to the next one because I know this one's not always going to be relevant to everyone. This is quite a key one for us, is thinking about what you've heard, and we've just given you a bit of a flavour of the Pakistani community's health inequalities today. We want you to kind of prioritise. So on the Mentee, you'll get to choose which one's first, and as you choose them, it will reduce, the list will reduce. So each one you allocate, it kind of moves through the list and moves down. And once you've allocated all 5, then click submit and you'll start to see on the screen the bars will start to move. And they'll move as more people vote, it moves around quite a lot. And one of the interesting bits when we've done this is that sometimes we do the same exercise with 2 different groups and you get very, very different bars. So it's a way of just giving us a bit of feedback to help reflect on this. So at the moment, there's definitely a strong focus on diabetes and cardiovascular disease reduction. And I think I have to say from the profile, this is one of the things that stood out really powerfully for me. And I think sometimes gets lost in us talking about South Asian communities. and not necessarily identifying that there are differences and that the Pakistani community has a particular challenge around diabetes and cardiovascular disease. But as I said, some of that very much links to some of the health behaviours. So it's not inevitable. There are things we can do that will change that. But as always, in the last few minutes, there's some changes and numbers go up and down as well. So you can, the last couple of people can change the order. And I have seen these flip around completely at the end. Brilliant. And if we move on to the next one. So this one again is a bit of a question mark and builds on the point that was raised before about how do we take this forward and how do we make sure it's real? So if you have any thoughts about how we should engage with the Pakistani community about this and how we can support more people to understand not just this profile, but the other profiles are there and that they can make a difference to their practice. So any thoughts or ideas? And there may be some replication for what you've said previously as well. Great. And I can see someone put in the chat there about at ward level. One of the challenges, real challenges we have, and when you read the report, you'll see this. The majority of research does not dig deep enough or is not big enough in terms of the sample for us to get, in most cases, for us to get to see the Pakistani community separate to the Indian or Bangladeshi community or to the general kind of BAME community. But it's definitely not large enough for us to be able to go beyond that and go actually what's happening at a ward. I think over time and some of the work that we're doing with the local NHS around particularly better understanding of GP data, pharmacy data may give us a better understanding at a much more local geographical level if there are differences. But we also have to protect people's identity. So we tend to suppress data. So we don't publish it where there are less than 5 people in a group. In some cases less than 10, depending how sensitive the information is. So there's some real challenges about how we, in the same way, how difficult it is to see what's happening differently to disabled Pakistani people compared to the overall general population Pakistani people. The data at the moment is still quite underdeveloped, and my hope is that through this work we're doing on profiles, everyone will get a bit better and see the value of ticking the boxes when we're asked about our identity, how important ticking those boxes are, because that really does help us when we're trying to analyze the data on the other end. And then I think this is the final one of the Menti questions, which is how would we measure success? So if we came back together in 5 years, say, or even 10 years, what would good look like? What would you want to see as the thing that would have changed for our Pakistani community in Birmingham? And some of these things you may say you take a long time to change. So tackling child poverty, for example, is likely to take quite a long time. But there are other things like diabetes where actually we know that if we can move that population to become more physically active, the payback starts within about a year. So you see that risk reduction. Actually, the payback on becoming physically active if you have high blood pressure takes about 3 weeks. And when we're talking about improving mental health and well-being, if you move to a 10-minute brisk walk every day, which is as effective as Prozac in treating mild to moderate depression, that impact starts within a month. So there are some real gains if we can make changes quite quickly in terms of driving these down. And not everything in public health takes decades, which I think gives us all hope that we can turn some of these numbers around. And I can see some statements that relate to that, which I think is really good. So I think that's the last of the Menti questions. Oh no, that's the final one. So having gone through all of those questions and having heard the discussion, where is your kind of mood at the end of today, and as we come towards the end of the session? And what I'd hope to happen is happening, which is moving the line slightly more to the right, which gives me hope that actually many of us taking part today will have felt energized and inspired by the profiles to deepen our understanding, to not just understand more, but also to take action. And I think to pick up Dr. Iqbal's challenge of, these are gaps, these are inequalities that our Pakistani community have experienced for many, many years in Birmingham. And this tool, I hope, will create an energy and a passion to start to close those gaps and change them, so that if we came together in 10 years' time again, Dr. Iqbal this time will be saying, well done, you've made a difference, and that we have moved our community to a healthier, happier, and more prosperous life. So I'm afraid Councillor Khan's had to leave us early today to get to another urgent council meeting, but I know she, if she were with us, would be one to say thank you to everyone for joining us today. I hope this has been really helpful. As Salma's put in the chat, do keep your eyes open. There is a race and healthcare summit that the NHS is coordinating for the 7th of December. If you want to get more involved in what we're doing to improve the health of our communities, we've just launched the Bolder Healthier Community Champions programme, which you can find on the council website, and that builds on the work we did during COVID to support more community members, citizens, volunteers, support practitioners in our communities to understand what's going on, how they can take action, how they can support their friends, their family, their community to make a difference. So do sign up as a Bolder Healthier champion and work with us as we move forward to try and reduce the gaps that are identified through this and the other profiles. So I hope today has been helpful. I hope it's been informative, and I hope that you will take the community profile back home to your friends, to your family, to your community organisation, to the organisations that you work with, and help us get this information out there, because the more that we understand the diversity of our community, the more that we understand each other, the more we as a city can work together to become a more equal, more equitable, and more inclusive city for all who live in it. Thank you very much for your time today, and I hope you have a great week. Thank you and goodbye.